Thank you to the chairman. Thank you to the whole organizer of this meeting for inviting me to present our clinical experience with metronomic chemotherapy for breast cancer treatment. During the last year, an increasing number of papers with metronomic chemotherapy for the treatment of breast cancer were published, but in clinical practice, metronomic chemotherapy remains a unique option. The first report were by Dr. Colleoni with a retrospective analysis for a combination with cyclophosphamide and methotrexate in metastatic breast cancer. And so since then, many other papers were published with a combination of chemotherapy, always in metastatic breast cancer, and also with metronomic chemotherapy as a single agent, such as with doxorubicin pegylated, or with vinorelbine or capecitabine alone, or metronomic chemotherapy in combination with hormone therapy, so such as our combination with fulvestrant in combination with CM. And other combinations are with biological agents, for example with bevacizumab or with trastuzumab. So, but what's new during 2015 from our group with metronomic chemotherapy for breast cancer treatment? I report you some experience from a phase 2 trial recently published in neoadjuvant setting. I report you the last results of a phase 3 trial in adjuvant setting presented by Dr. Colleoni at last ASCO meeting. And I present you also a preliminary analysis of our phase 2 trial in metastatic setting with a combination of metronomic chemotherapy. So let's go on to see the results of a phase 2 trial in neoadjuvant treatment. This is an example of how you can use metronomic chemotherapy sequentially to chemotherapy at standard dose, and is for triple-negative breast cancer. And why we designed this trial is because chemotherapy, including anthracycline and taxane, have improved the clinical outcome in terms of PCR when administered as preoperative treatment, but there is also an mounting evidence of the existence of a link between BRCA deficiency and the basal-like phenotype. So preclinical study has shown that the loss of BRCA function increased sensitivity to DNA damaging agents like cisplatin and like alkylating agents, and metronomic chemotherapy with the use of cyclophosphamide can produce a prolonged anti-angiogenic effect of the drug. So we design a phase 2 trial for triple-negative breast cancer with a stage 2 clinical T2, T4 with or without axillary lymph node involvement, without evidence of metastasis. All patients received 4 cycles of a combination with epirubicin, cisplatin, fluorouracil in infusional continuous, followed by weekly paclitaxel 3 weeks on, 1 week off, in combination with cyclophosphamide at a fixed dose, oral 50 milligrams per day. The primary endpoint for this trial was the change of Ki-67, and the secondary endpoints were PCR and overall response rate. So here there are the baseline tumor characteristics. We enrolled 34 patients from June 2009 to May 2013. The median age of patients were 45 years. The vast majority of patients were at stage 3, 3A, 3B, and 3C, and they had at biopsy a grade 3 tumor and a higher median range of Ki-67 percentage of about 60%. Here the results for Ki-67, the mean reduction of Ki-67 was about 41%, and for overall response rate, 25 patients achieve a partial response, 6 patients achieve a complete clinical response, and pathological complete response was observed in 56% of patients. The treatment was well tolerated, and low number of grade 4 neutropenia and transaminitis in 18% of patients, and other adverse events were mucositis, neuropathy, and nausea. So in conclusion, this phase 2 study, even if is with a small sample size and with the absence of a comparative treatment arm, the activity and the good tolerability of this combination with chemotherapy at standard dose followed by a metronomic chemotherapy show a favorable activity and a good tolerability, suggesting to retest this regimen in further studies. And we used 3 drugs in metronomic low-dose schedule: fluorouracil, cyclophosphamide, and paclitaxel. So probably we enhance the antiangiogenic effect of an higher scheme of chemotherapy. So move on with the known results of a phase 3 trial presented at last CASCO meeting by Dr. Coleoni. This is a study with a low dose of cyclophosphamide and methotrexate for hormone receptor negative early breast cancer. The question here were: what is the value of a low-dose chemotherapy regimen, hypothesizing that have an antiangiogenic effect, administered followed a standard chemotherapy regimen? And what is the rule of this regimen for triple-negative breast cancer? So all patients were randomized to receive, after induction chemotherapy of 4 or 6 months, a CM maintenance versus observation. The primary endpoint for this trial was disease-free survival, and the secondary endpoints were breast cancer-free interval, distant recurrence-free interval, and overall survival. The CM was administered at a fixed dose of 50 milligrams per day of cyclophosphamide and methotrexate at 2.5 milligrams twice a day on day 1 and day 2 every week. All eligible patients were patients pre or post-menopausal with hormone receptor negative invasive breast cancer, any nodal status, and any HER2 status. Remember that the trial started in 2001 when trastuzumab was not approved yet for adjuvant treatment. The disease confined to breast or axillary node without evidence of residual disease and no evidence of metastasis. We received an approved induction chemo regimen. So some small statistical consideration is important for the results of this trial. The original protocol design was designed for a sample size of 900 patients for an hazard ratio of 0.7 and an 80% of power. But in 2010, we observed that about 14 patients did not start CM maintenance, so we need to enlarge the sample size to more than 1,000 patients for maintain an hazard ratio of 0.7 at a power of 72%. So this current analysis is about 1,018 one patient. Here we have the patient characteristics. The median age was 52 years. The vast majority of patients were at grade 3 of disease, and 75% were triple negative, and 42% had a lymph node invasion. So, and now the results. There's no statistical difference between the two arms in terms of disease-free survival for overall population. And there's not even no advantage from CM in maintenance in terms of breast cancer-free interval and distant recurrence-free interval. But if we analyze the population of triple-negative breast cancer and the node-positive and triple-negative breast cancer, you can see as the advantage in terms of disease-free survival is increased by CM of about 4% for triple-negative population and of about 8% in terms in a subpopulation of patients with node-positive and triple-negative. Considering that 13 patients did not start CM, we analyzed also disease-free survival for patients who receive or not a fully dosage of CM, and the greater benefit was observed in patients triple-negative who received more than 75% of CM. Here we report the adverse event. Grade 3 and grade 4 of leukopenia and neutropenia was the most reported. but also the increase of SGOT, SGPT is the most limited toxicity for CM schedule, and a small number of patients have dysuria or infection. So in conclusion, in overall population, CM maintenance does not add a benefit in terms of disease-free survival, but for women with triple negative and for triple negative at no positive, there's a larger benefit for the addition of CM after an induction chemotherapy. So IBCSG 22 is the largest trial for triple negative subpopulation and offers an important translational study that we tried to conduct to identify if there were some prognostic or predictive factor to the response at CM maintenance. So we investigated the role of TILs in patients treated with CM maintenance in trial 2200 and hypothesizing that metronomic chemotherapy, as you know, can facilitate immunostimulation. So this is only to show you as TILs was evaluated according to International TILs Working Group. TILs were reported in the stromal compartment. And in 2200, we analyzed TILs in 672 patients. The median TIL score was about 18%, and 119 patients had a lymphocytes predominant breast cancer. If we consider, there's a lack of a table, but don't worry. If we consider population with lymphocytes predominant breast cancer versus non-lymphocyte predominant breast cancer, we can see as CM maintenance is a prognostic and predictive factor to, in terms of breast cancer-free interval. So, metronomic cyclophosphamide probably restores the proliferative capacity of effectors T cell as well as cytotoxic NK cell suppressing Treg inhibitors. And interesting, the risk reduction observed in patients who receive CM with higher TILs suggests that TILs may predict the clinical benefit from metronomic chemotherapy. So this hypothesis deserving further investigation in the lymphocyte subpopulation involved in tumor immunity. But let's go to the last preliminary analysis in metastatic setting. This is a phase 2 trial with a metronomic oral chemotherapy in combination with cyclophosphamide plus capecitabine plus vinorelbine in metastatic breast cancer patients. Eligible patients are patients with metastatic diagnosis of breast cancer, attaining estrogen receptor status, but HER2 negative disease. So we analyze separately two cohorts of patients, endocrine positive versus triple negative cohort. They may have or not received any line of treatment for their metastatic disease. So we analyze separately an untreated cohort versus a pretreated cohort. And the primary endpoint for this trial was time to progression, analyzed separately from untreated and pretreated patients. Vinorelbine, cyclophosphamide, and capecitabine was administered at a fixed dose. Here we have the preliminary analysis only for endocrine positive cohort. The cohort of untreated patient is closed because we reached the sample size. Instead, the pretreated cohort is a preliminary analysis because the sample size is about 63 patients, and we analyzed here only 46 patients. As you can see, in untreated the population, there is an half of patients with both involvement visceral and non-visceral disease, and in pretreated the vast majority of patients with visceral and non-visceral disease. Here we can see the time to progression of untreated, that is very impressively for population untreated of about 26 months in first line for metastatic setting endocrine positive HER2 negative disease. The pretreated population reached a median time to progression of 9.6 months, but if you see at response rate, only 35% of patients reach response rate for untreated and for pretreated. So comparingly, by an indirect comparison from scheme of chemotherapy at higher dose, a standard dose, with treatment and with metronomic chemotherapy, you can see that response rate is much higher for patients who receive the standard chemotherapy, but the progression-free survival is shorter than our observed in this phase 2 trial, with a lower response rate. The treatment was well tolerated, no grade 4 of adverse event. The most frequent is always neutropenia, leukopenia, and transaminitis. So in conclusion, from our experience, the metronomic chemotherapy represents a valid option not only for palliative treatment, but in all settings of disease. Neoadjuvant application, as you can see, in combination with standard chemotherapy, as adjuvant treatment, as a maintenance to a standard regimen, and in metastatic setting. Though the results of a 2200 trial are not statistically significant, they showed a clinically significant difference in triple-negative breast cancer at a higher risk. So you can consider CM maintenance in this higher risk of patients as adjuvant treatment. In metastatic setting, a combination of metronomic chemotherapy should be evaluated also as first line, considering the prolonged time to progression that we obtained and the good tolerability profile. I would like to thank all of you and patients who enrolled in this trial, all my colleagues, Dr. Coleoni. Thank you.